Thank you so much. It's great to be here today. I have to say, I really have been honored to be here in the room today. It's been a remarkable set of conversations. And I realize we're in kind of a new world, a small group here in the room, but over 1,000 who are getting to participate in this meeting via its hybrid nature. And for me, it makes the world a little bit smaller, and it punctures some of the potential pretensions of getting small groups together in universities to talk about important issues that affect communities in such a powerful way. And I just want to say, I really want to thank Louise Ivers and her fantastic group at the Harvard Global Health Institute. And as an inaugural set of conversations, I think this is just so promising. And unlike some of my colleagues, I sometimes do get discouraged and I have a potential for cynicism. But I have to say, listening to the remarks today and their probing and critical character has been so important to me, and I feel so fortunate to be part of this collective conversation. And in a sense, that's what the last session returns to, a theme that has been threaded in and out of all the conversations today: community response to emerging infectious diseases. There's a saying that all politics is local, but I think in a similar way, all global health is local. And by that, I don't mean just contained in small communities, but it has to start at communities where the need is greatest, where people are sick and suffering, and we see the embodiment of coloniality, racism, slavery written into their bodies. And it's community engagement that is the spark that has the potential to radically change global health. And I should say, radically change institutions like elite universities like Harvard. That part of what we're talking about, and I think in a sense, Joe Gahn just said this, universities can imperialize and colonialize the world, or they can be potentially used, and I see the glimmer of this in the room today, as a force of global good. And that involves the radical reconsideration of what universities do, what kind of knowledge they produce, and not only what kind of knowledge they produce, but the ability to deliver that knowledge in ways that affect people in the greatest need around the world, certainly in the global South, but in a rich country like the United States, where disparities are so profoundly significant and growing. So there is so much for us to learn from the experience of the work that is done in communities. We have really a fantastic panel to conclude today. My colleague Joya Mukherjee, who's been a central leader at Partners in Health and is my colleague in the Department of Global Health and Social Medicine at Harvard Medical School and in the Division of Global Health Equity at Brigham and Women's Hospital. Jean-Gregory Jerome, who is the Senior Advisor for Health Systems Strengthening at Partners in Health. Bizola Ojikutu, who is currently the Executive Director of the Boston Public Health Commission and has worked tirelessly during the COVID pandemic to engage communities. And very fortunately, this panel will be moderated by Helen Branswell. And probably everyone in this room knows Helen Branswell's work. But in a time of misinformation and brutal disinformation intentionally delivered to confuse and distract from the critical issues of what science and medicine can do and can do effectively, Helen Branswell has been a real visionary and light and one of the great writers. And I think when we write the history of the COVID pandemic, her work and the work of her colleagues at STAT will be recognized as a clear voice in the midst of disastrous debates. So let me call upon the panel and Helen Branswell to moderate. Thank you very much.
Hi, good afternoon, and thank you so much for that very, very generous introduction. I'm really looking forward to this next 45 minutes or so. I'd like to explain for a second how this is going to work. I'm going to ask some questions, and I'm certain that as you're hearing the answers, you'll be thinking of your own questions, and sort of maybe 15 or 20 minutes into the discussion, I'll ask for questions from the audience, so please do make notes and have questions at the ready if you want. And then we'll close at the end with comments from the various panelists. Please also, if you're not hearing us, wave your hands. You know, we tend to drop mics sometimes, and if you can't hear us, please let us know. I think to start, it would be useful to sort of unpack the premise of this panel a little bit, to explore what we're going to be talking about here regarding community engagement and community-centered responses in an outbreak setting. So I've asked Joya if she could give us an explanation off the top. How can, could you start by maybe giving us an example of how this works from your own experience?
Great. Thank you, Helen, and thank you to Louise and the staff at the Harvard Global Health Institute. This has been so great. Each and every panel, I've heard something that I wanted to say, so I'm not going to repeat the words of every other panelist. But I will say that there is a brutality to the global security architecture. There's a racism to the global security architecture, and there is an imperial nature to outbreak control. And if we are to fight for justice, we have to be involved in community-centered approaches, but that often we talk about the top-down approach and the bottom-up approach, and we have to reject that there is a top and a bottom. The approach to epidemics must be fundamentally a collaborative approach, bringing people from all lived experience into the mix. And in my own work as a physician, I think what I say to our team is, I have carrots. If we are working together to make the stone soup that we will all eat, as a physician, I can bring one thing, it is carrots, but I need the driver to bring the meat, and I need the person who's suffering to provide the salt. And so we have to develop a collaborative approach. In our first work in HIV in Haiti many years ago, we started by just treating the sickest people with antiretroviral therapy because that is what they needed, they wanted, they demanded. And many experts around the world said it's not possible, you can't do it, African people can't tell time, etc. You know the story. But it was the people themselves who demanded that treatment. But interestingly, it wasn't about treatment alone. And this is where the collaborative approach is so important. We, in our follow-up forms, once people had started antiretroviral therapy, and Louise will remember this well, as will Gregory, we had for the chief complaint at the first follow-up visit, as our drop-down questions, job, food, housing, school. And an expert came and said, these aren't chief complaints. And we said, you haven't listened to the community, because the chief complaints that people had were those material needs of their survival. And if we look at infectious diseases, emerging or not, as a disease rather than a biosocial phenomenon that impoverishes people, that puts people on the knife edge of survival, then we do not understand that. And we saw that in COVID. The very people who were unhoused, who didn't have the option of working from home, they were the ones who were affected in this country and around the world. So to think about a community-based approach, a community-centered approach, is to understand that the experience of everyone has to shape the response. And I have lots of examples of that, and we'll get back to Ebola later on. But asking people, what can I do with you together to fight this fight? And again, about terminology, when we think about decolonization, these terms are so passive. This is a fight that we have to make common cause and work together for justice. And so when we work with communities and say, what can I do? What do you need from me? And often the question is about materiality of suffering. I need food, I need a house. And it's very easy for experts to say, no, but I mean, in terms of the drugs. So we just paper over those material needs. And so because we're working in this legacy of violence, of violent colonialism, of violent oppression, racism, patriarchy, we have to position ourselves as a partner and a learner. And the people that I've learned the most about from addressing epidemics or health problems in general are the people who are suffering from those problems, who can tell me, if I open the question, these are the things I need. And medicines can be one carrot in that soup, but the soup is a much, much broader thing, and that's what we learn from community.
Thank you very much. You know, it seems, I'm going to sound naive here. It seems to me almost that it should be accepted, the norm, that you involve the community and that the people who you're trying to help should tell you what they need and how they are willing to accept your help. But I take it that's not so, or not always so. Gregory, I'm curious about your thoughts here. Can you talk to us a bit about some of the responses that you've worked on and when this didn't happen and how it affected the quality of the response?
Yes, thank you for this opportunity to really be part of this conversation. I think in this sense, what really come to my mind is I can refer to the cholera outbreak in Haiti, especially at the beginning. Back in 2010, when this outbreak started, and this was kind of new for the people who were affected by this condition, new for the providers also, because this was the first ever cholera outbreak in Haiti, and also new to the public health environment. So there was like a sense of panic and a sense of fear among everybody. And I think the failure that I can mention was around communication, lack of communication, miscommunication. So when I say lack of communication is, the nature of in Haiti, especially to kind of get the message out to the communities so that they understand the phenomenon that was really affecting them, and miscommunication as well in terms of how people really they perceived this condition at the beginning, to the point that in some region in the country, especially in the southern part of the country, so because the message, the right message didn't get to the people to really understand what was going on. We saw, and because of this fear also, people really started, in their own understanding, their own perspective on things, taking it to another dimension to say, oh, okay, this was due to the voodoo priest, who were cursing some of the communities. And that started really in the very wrong way that some of those voodoo priests were really lynching. And there were like 45 of them. So I think for me, this really resonated to the fact that in order to address the right response, we really need also to understand, the communities, to understand how people really, what's their perspective on things. And the right way to really do that, even before, starting with the standard public health approach, the biomedical approach on situation like this, is really to make sure that we get the people's opinion, get their, how do they understand the situation that they are living. And to go back to what Joa was saying, this collaborative approach, and also put things into context. So I can also mention briefly, like during the COVID pandemic in Haiti, we heard this, standard approach that messages around like COVID, stay home. But for some people, it's like, which home are we talking about? So some people didn't even have a place to stay. And or the place that, they had to stay, it was so, crowded. And, it was really impossible. The kind of public health messages that were around COVID that we could really, relatively easily apply here couldn't really be applied to Haiti. Say people stay home, or like you need to get food supply, but people are living like on a daily basis. So this kind of, contextual situation needs to really be understood and really incorporated into the public health intervention. So the social medicine aspect, the individual aspect need to be considered.
Great, thank you. Let's talk about this in the context of the US for a little bit. We've gone through a really punishing 3 years with COVID, and then last year Mpox on top of it. Bisola, how well does the US do in fostering community-based responses? With COVID, it felt, sorry to use this term, but kind of top down. People were told not to go to beaches, tennis court nets were taken down. Things that were actually counterproductive occurred. Although last year, I would say with the Mpox outbreak, it felt much more like there was community engagement and much more work done with the community that was at highest risks. What are your thoughts?
So first of all, thank you for inviting me. I'm honored to be here. I would say that the short answer is that we're not good at it. And I think that probably everyone in this room who's worked in the US would know that probably is the best answer. But just taking a step back for a second, the way that we've sort of been looking at this is community-centered responses during urgency, emergencies, community-informed responses, community-based responses. I think we need to take it one step further. Our responses need to be community-led, okay? And so that's really moving into a place where we're shifting power into community. I think another way to look at this is that when we have emergency responses, the way that we work is that it's often reactive that we bring community in. It's often delayed, and we do it in a functional sense. We need them for something. And so that is what I would call community outreach. It's unidirectional. It means that you go out, you give people a message, or you get them to enroll in something, or you get them to do something. Now, the more ideal response was discussed by Dr. Brand. You said community engagement. Okay, so that's partnership, that's sharing resources, that's sharing power, okay? But again, one step further, and what we should be learning from COVID-19, it's really community empowerment that shifts the dial. And it also means shifting power into community. It means resources going directly into communities to get this work done. And that can be very uncomfortable, I think, as we start to talk about what universities do, what governments do, and how we look at resource allocation for the purpose of actually ending emergencies. So let me just give you an example, and then I'll talk about Mpox for a second. So if you think back to 2020 and you think back to the summer and then into the fall when there were the initial clinical trials. So if you think about that, you remember that there was a lot of concern about diversity in the clinical trials and generalizability of the findings. And what about mistrust if we don't have enough people of color? Because at the time, mortality was 2 times higher in Black, Latinx, Indigenous populations than white their white counterparts. And so at the time, we did a lot of community outreach. There was money that was going, pharma was working with this one, that one around the country. But at the same time, there were communities that were saying, but wait a minute, we can do this, we can help enroll people, we can try to mobilize this. We know that Operation Warp Speed is occurring, but we can be the people who are actually doing the rollout of the vaccines. And so communities actually mobilize themselves in many ways. Here in Boston, we had the Black Boston COVID Coalition, we had La Colaborativa, which is already sort of working in the Latinx community, Equity Now and Beyond works in the immigrant community. So it was this type of work, people getting together, mobilizing, working amongst themselves to get it done that actually shifted things here in Boston. I'm telling you that from my own experience, okay? We actually closed the vaccination racial and ethnic disparities gap in April 2022, and it's because we were funding these collaborations and these coalitions. That does not happen everywhere, and it's something that we should take as a lesson learned. Now, when we look at Mpox, so you said that it appeared different. Well, let me tell you just from the inside, I'll say that it wasn't so different, actually. And the reason why I say that is because initially, we as a public health community, I'm really talking about public health, we were afraid to talk about sex. We don't like talking about sex and sexual diversity. We don't like to talk about that. So we were avoiding those conversations. We were making a generalizable statement about how everybody could get Mpox, therefore we should all be concerned, we should all be wiping down our surfaces and washing our hands. Instead of telling people, hey, people who are sexually active, men who have sex with men, they are at highest risk, and we need to reach out to them and leaders within their community. By community, I define that as people who have shared beliefs, shared norms, shared language in some cases. Just reach into the diverse communities there and say, you lead this. You do the messaging. You get people to be vaccinated. You get people to come to the table and to discuss how we can end this. When that happened, I think we saw a shift. It happened more quickly, and that's maybe what we saw, is that it really did, you did see a rise in leadership. But I think that is the same example as community leadership. Community-led responses are really key.
That's great, and thank you for correcting me, because you're right on about that. Yeah, that your answer makes me want to talk a bit more about, you know, the U.S., but I do want to go further afield after that. There's, you know, an enormous problem right now with mistrust, distrust. Was talked about that in the last panel, and you know, one of the things I think about, having spent the last 3 years covering COVID, is that we learned a lot of stuff that is going to be really useful the next time this happens, and we may not be able to use a lot of it because people will be so resistant to masking. I mean, you know, if the fatality rate is higher, maybe that will change, but there's been such a polarization around public health. Public health departments have had power stripped from them across the nation. I mean, I find this quite frightening, to be honest. If there was more of the type of engagement that you're talking about, could we break down that distrust, mistrust within communities? And I'd like all of your thoughts on that, please.
Yeah, I want to jump in because I also want to add to what Basolo is saying. I think part of the problem is we're talking about during outbreaks. What about the other times? And I think what I've seen around the world, including in the US, is why now? Why do you care about me now? You know, my sister had a broken leg, couldn't get fixed. I've been on a waiting list, you know, forever for, you know, to get a mammogram. So you can't suddenly run in because it's convenient for you. And I think that's part of the brutality of this emerging infectious disease, global health security architecture. It's clear to people in community that you don't really care about me, you care about you. Right? You're trying to protect it from coming to your doorstep. And we saw this a lot in Ebola in West Africa, where people didn't trust the health system because the health system sucked. It wasn't like, oh, it's Ebola. They don't want to go in there because every hospital was a death trap before Ebola. Right? And so it's hard to get people to engage suddenly because it's worrisome to us in the West. And so that's why we have to focus on community participatory approaches now, all the time. Improve health through a horizontal collaborative approach so that when these things happen, you know, and you know, we were talking a bit at lunch about Rwanda. Rwanda had a beautiful response to COVID. And within a month, they had 134 cases from their first few cases, whereas Georgia had 8,000. Right? And they're the same size. And what was that about? It was about the people are used to the government actually doing healthcare, doing it well. And you can say what you want about the governance or whatever, but people understand that the health system is actually there to provide services for them. And I think we have to build that in the in-between times if we think we're going to be able to respond to a pandemic.
Yeah, I can probably elaborate a little bit on that, sharing a little bit of my experience for having worked in Sierra Leone, after the Ebola, and how really people reacted during the COVID-19 pandemic. And I think it's related to the vaccine campaign. Even myself, and I was really impressed by the way that people really kind of, even if the system itself is not really optimal and really a broken health system, but in terms of trust in the public health authorities there. When we even they launched the vaccine campaign for COVID, so I myself was kind of skeptical that people would not really be willing to take the vaccine, especially that COVID was not really, didn't really hit hard really too much there. But over time, I saw that how people were really lining up to get the vaccine because there was this trust also in the public health context. So I think it's really important that, and also because I think there is a huge emphasis in communities like this in the involvement of the leaders of the community, and also making sure that from the villages, to the chiefdom, as they call them, people are really involved in passing the messages to the community so that they can really understand how it's important for them for things like this to take the vaccine and really really collaborate.
So if I could chime in just rather briefly. So prior to taking on this role as Commissioner of Public Health for the City of Boston, my academic work was actually focused on understanding mistrust and conspiracy theories, but it was really related to HIV. Then we shifted into COVID-19. So this is an issue that people oftentimes ask me, so what should we do about mistrust? Similarly to this, like what are we gonna do now that people don't trust? This is not a new phenomenon. This has nothing, it's been amplified, highlighted, it's been written about. We all know that it's there. Our systems have never proven themselves to be trustworthy, therefore people don't trust them. I mean, this is obvious, and so many people will talk about Tuskegee in the Black community. This is not about an episode. This was not about an event. This is about the chronicity of dysfunction, the chronicity of structural violence, what's been going on for centuries. So it's nothing new, and it's been going on for a long time. So the question is, what do you do about it? Well, a lot of times people will say, well, let's be more transparent. Let's, as I said, be more engaged with community partners. Let's develop real, collaborative structures. And I think that's great. But what we need to do is sincerely invest in the inequities that have caused the problem. Yes. I mean, that has to be a real investment. It has to be earnest. Yes, it has to be sustained. It has to be what we say we are going to do. Everybody thought, and I'm sure we all heard this, COVID was going to be an inflection point. We were going to change. There was going to be real structural change, a true shift in how systems work. Has that happened? No. So then how sincere were we in the first place? And that's what I'm saying. If you really want trust, if you really want people to trust, we have to be sincere and do things differently. So.
Well, I was going to ask, about how if you built your responses around community-centered actions and found out what people wanted, whether it would help to build infrastructure and help to build expertise in other settings, particularly I'm thinking here. But it sounds like from what you're saying that we have to do it before, not after. And how do you get... continuously. But how do you get people to take that seriously and invest in that? Because you know, you can see what's happening now. Everybody's acting like we just went through a 100-year storm, and now we have another 100 years in which we can just ignore infectious diseases and go on about our business. I mean, they don't want to spend any more money on COVID here, and God knows on whatever else. So I just wonder how if this event did not incite, you know, inspire people to take infectious diseases seriously and plan for and work towards maintaining preparedness, what is it going to take? Anybody got an answer?
Yeah, I'm happy to answer, but I'll let one of you guys go first.
You know, because I just came from the budget breakfast, so I've been talking with city councilors all morning about this issue. Let me just weigh in and say that I think it's about having the right leaders in place, you know, and I think we underestimate who we put in places of power, and we need to take that very, very seriously. I think it's also just about being persistent, you know, and I say that I'm trying to be hopeful, you know what I mean? I'm trying to say that I've talked to commissioners, and let's just talk, you know, domestically for a minute. I've talked to my colleagues across the country. There are commissioners of public health. There are people who are working in departments of public health, and they believe that this is what we should do. But at the same time, we are getting money taken from our COVID lines and pulled into other emergencies, other crises. So it's up to me to fight the good fight. I mean, literally, it means talking to people and trying to develop the right strategies to get them to let us keep 5 million here, because we know we need to prepare communities. And one of the things that we're doing here in Boston, I'm trying to advocate for, is having a community health empowerment fund. So actually having money that's there, that's ready to fund these different coalitions, so that they can not only work on continued efforts under COVID, but also all the other disparities that we're talking about. I mean, you know, we could run the gamut of all the disparities and all the issues that we have to deal with. So I'd have to say it really is about that. And then in addition, I would also add that it's really about communities standing up for themselves.
Okay.
You know, so I'll just say this and then pass it on. I don't know how many of you know about the Black AIDS Institute. So it's an organization that started in 1999 by Phil Wilson, a Black gay man, who basically came together. It came together based on a lot of these issues of mistrust. So in other words, they said we can do this for ourselves, and the actual model is our power, our people, our problem, our solution. Okay, so it is about communities saying, you know what, we have resilience. We can do this ourselves, and coming to the table, which they do. If you say, here, open the door, and you say, here, come to the table, let's talk about it, and doing some advocacy on their own.
Jaya, did you want to add something?
I mean, I think just to probably elaborate also this, I think this approach of having, like after really experiencing situation like this, we need to have a sort of way of creating a space, creating platform where the conversation can continue. Mm-hmm. So one thing that, for instance, I really appreciate like seeing in Sierra Leone is like the Sierra Leone Association of Ebola Survivors, and they are really actively involved also in, you know, and trying to influence and, you know, do advocacy work. And they need obviously to be more empowered over time. But I think, Bill, on what, you know, you just said, it's really to make sure that we create platform where we remind ourselves that really that really has happened. We didn't handle it well, and we need to get ready for the next, you know, for the next emergency response that we need to for other outbreaks like this.
Yeah, I would just add on that, like, I think the platform that Gregory is talking about has to be this collaborative platform. I think it is about leadership, as Basola is saying, but I would say it's much more about civil society. We have to make spaces for affected people to be decision makers. And good leaders will do that, of course, so leadership is important. But if we don't create the space, I mean, what to me defines more than anything else the success in the AIDS movement is people living with AIDS at the table every day. You cannot have a meeting without, you cannot have leadership without that. When we hear about the great work in Colombia, this is civil society taking power. And I think criminalizing dissent, as we saw this week in Tennessee, is one of the most dangerous things that can happen toward any kind of equitable response to whether it's a pandemic or the massive disparities we see, without any infectious disease in the US.
Okay, I think we have time for one question. Is there somebody in the audience? Maybe if it's the question is short, the answer is quick, we will get to. Wait, you're going to get a mic.
Sorry.
All right. I just want to say how rich this conversation has been all day, as many people have said. But one of the things that I haven't heard you talk about, and I served as health commissioner in New York City and in New York State, is what's happened to government, and in particular to public health, and the extreme privatization of government activities. It was on full display during COVID. Private companies providing the tests, private companies providing the vaccine, and the loss of, government invested a lot in the vaccine, but it's private manufacturers assume we're going to be paying private prices for these. And I just would like, I would like you to say something about that, because the notion that communities can just pull power from numbers is one that doesn't take into account the real realignment that we've seen in, say, the last 50 years that has so undercut the effectiveness of government public health.
Okay, no, okay. Yeah, Mary, amen to that. And, I think when we think about the dialectic that's needed to assure human rights, it really has to have both a community part and a government part, because private corporations have absolutely no interest or responsibility in delivering in human rights. And so because governments and the public sector has so abdicated, particularly in this country, abdicated any sort of public contract, I think it becomes very impossible for communities to really, now we're trying, but I think the public sort of rebuilding a public contract, and we've tried to do this at Partners in Health. We worked very closely to help draft the Public Health Jobs Score Act. We got that money to go to Immokalee, Florida, one of the most heavily hit communities, majority migrants from Mexico, Guatemala, and Haiti. And when that money got there, to hire Haitian community health workers to work for, and Mexican and Guatemalan, to work for the federally qualified, the closest thing we have to public clinics, the county, Collier County, turned that money back to the feds. And there were protests outside of the thing saying, oh, this is violating our health freedom. We need to figure out who's paying for those protests, because that is a corporatization that we don't want this public contract. So we have to follow the money, and we have to really make that plain.
No, I totally agree with that. But let me go back to this issue of privatization and what we saw during COVID-19. I think we all saw this incredible, enormous shift to private industry in controlling what was happening, and not just supplying, but actually making the decisions. And that was very concerning, but it was also, the reason for that was because public health infrastructure has been so devalued, so underappreciated for decades, and underfunded. That's where I was going. That was my next under, right? And underfunded for decades. And no, but it's not only that it's underfunded, but it's the way that it's been funded. It's been funded to focus in on disease entities as opposed to the infrastructure, our people, our lab sources, our laboratory services, our data, everything that makes a public health system what it should be in this country. If that was not the case, private industry would not have an opening. And I think that is what we need to learn from this. And where I say government comes in is that I do think there has been an understanding of this. Now, whether or not people are really truly acting on it, I don't know. The CDC is putting a large sum of money into jurisdictions to focus in on building public health infrastructure. This is a once in a lifetime. It has not happened before here in the United States. If it happens again, that's great. It's not a lot of, here in Boston, we got 8.9 million. That's not a lot of money, but it's something. I think what I was concerned about was that with the American Rescue Plan Act, which is the $1.9 trillion that the United States gave out and spread around the country, At no time was there a plan to mandate community involvement in exactly where that money went, okay? Now, health departments may have chosen to do that, but at the top, that was never the plan. It went to cities, it went to counties, it went to different jurisdictions. And I think that is where a lot of things need to change, because it is communities who can make those decisions about transformative investments in actually what will happen the next time we have a pandemic.
Would you guys mind if we take another question instead of doing the closing comments?
No.
I think the gentleman there wanted, can somebody get him a mic, please?
Yes.
Thank you. I'll sit so I don't block the view for the folks behind. I'm an ER physician, and that's the context of my question. Yesterday on television, the gentleman who was the chief medical officer of the hospital that handled all the shootings made a statement that said, I'm a doctor, so I don't know what the right solution is. And he was obviously calling for gun control, but those were the words he used. And I think physicians have been taught to be skittish around taking political positions. So thinking about, and this has not always been the case, PSR and PHR have literally changed the world through the Landmine Ban Treaty and their role in nuclear disarmament, right? I'm thinking about Joya's chief complaint list. How do we get the American medical professional societies, all of them, who won't even come out in support of universal health coverage, to come out in support of universal basic income?
I mean, I guess it's not my, in some ways, it's.
I didn't mean to put you on a spot.
No,
but
it's fine. I don't mind.
Like that's where we
I don't
should
mind
be.
because I have no skittishness about politics, because, I mean, I believe what Virchow said about medicine being inherently political. And I think that I'm not as concerned about making a medical professional group do this or that. But I will listen to people and try to have people hold us accountable. And FDR famously said, I know what to do when he was drafting the New Deal, but he said, you guys have to make me do it. He probably didn't say you guys. So I think it's really about making common cause with people who are fighting and building public institutions, because without public institutions, we don't have a shot. Because there is no incentive, unfortunately. I mean, when I started doing AIDS work many years ago, I had a discussion with a sort of progressive economist, if there are such things, and I said, well, can't we show that there's some merit to saving this person's life who's a peasant farmer in Haiti? He said, there's no way, because that person doesn't contribute to the economy, and the only measure we have is the contribution to the economy. So until we value people's lives for the existential meaning of them, we have to really listen to voices and have a public approach. Otherwise, there are many of our colleagues in the medical profession who are part of a capitalist structure, as we all are, really. And so I'm not as worried about changing our profession.
No, please.
No, I just wanted to, I think we kind of commented also on one aspect of this, which is like, making sure that we got the right people in terms of leadership, at the right position. And I think for me, it's also create this movement. What we are doing now, I think it's not superficial, it's really deep and profound. And I think it's like preaching the gospel so that people continue to hear this kind of different approach and take advantage of momentum. And just like we said, COVID-19 has really created a momentum really to show disparities and to show some other approach in emerging infectious diseases like this. But I think we have not really taken as much as we could for this momentum that has created, and we need to make sure that we don't really lose this momentum and continue to create this movement around all these all this word that we are using now, decolonization, and also like making sure that we kind of, in terms of disparities, and give voice to the people who are really suffering most from those conditions, and who don't really have access to the basics. So I think that's something we need to continue to do.
Last word, Judy.
Oh, my goodness. Okay. So actually, I was going to go back to the question that was asked about medical societies, because I agree with you, Joya. I don't pay so much attention to our professional medical societies, honestly. I'm not a member of the AMA. However, I was recently looking at the amount that they spend on lobbying. And if you combine the amount that the American Medical Association and the American Hospital Association spend on lobbying alone, I think it was in 2020, it was like $47 million. Compare that to what the American Public Health Association spends on lobbying. Somebody guess. $97,000. That was in 2019. I think it went up to 115 in 2020. I think what's missing here is we don't value this work. We don't value human lives, and we also just don't value the public good, public health, the way that we collectively should be focused in on the health and well-being within communities, amongst populations. Something is just not right here. It's going to cause really a shift philosophically in how we look at the work that all of us are doing. So I'll leave it there and just say that some change has to occur. The structural change that changes our systems and how much we truly value public health needs to change.
Wow. Interesting.